That's a very good question, because indeed now we have multiple options in first line, and probably more will come in the near future. And indeed, it's important to balance the quality of life, because these patients are now living more and more and more, even more. So it's important to maintain a good quality of life and a meaningful life for them. So, but still, we know that if we start with amivantamab lazertinib, we can give chemotherapy only in the second line. That's what we have so far. Eventually, the ADCs that will probably come soon also to Europe. If we start with chemotherapy plus osimertinib, upon progression, we could re-challenge with chemotherapy. We also have the poster now at ELCC showing this patterns of re-challenge, and also showing that patients still derive benefit when re-challenge with chemotherapy upon progression. In the US, people are already actually continuing osimertinib with this chemotherapy based on the COMPEL data that was presented last year. But another possibility would to give the Mariposa 2 scheme, so giving chemotherapy, so re-challenge of chemotherapy, but with amivantamab as the EGFR blocking strategy. And then, of course, if we start with osimertinib only, you could do that, reserving chemotherapy and amivantamab for the second line. But I think that if you have a patient that is fit, that wants to prolong his or her life, then I would propose upfront the combination strategies, and which one, I think it's something that we actually now, it's our first consultations are becoming increasingly complex, because what I just told you, we are also telling to the patients and sometimes and explaining them what are the possibilities if you choose A or B. And so they are actively engaging in these discussions, but it's really, as you say, very important to think about all of this up front, because this will condition what we'll give in second.